Uh, Good morning. Now I'm going to discuss third lecture in the series of growth and development. And we discussed growth in general in the first lecture and then short stature mainly in the second lecture. Today we are going to discuss a very important topic, the most frequent reason of the pediatric patient to visit the OPD, that is failure to thrive. Okay. Almost 10 to 15% of the patients in pediatric OPD came with the complaint of that the baby is not growing properly. So failure to thrive is the important uh, complaint of the patient, pediatric patient, mothers and fathers, that their baby is not growing adequately or properly. Now, failure to thrive is a descriptive term. It is not an this is a spectrum of various symptoms. This is not a definitive diagnosis, and it is used in infant and children up to 5 years of age, whose physical growth is significantly less than peers of the same age and sex. Okay, so it is a descriptive term. Failure to thrive, most literature accepts any of the following four parameters. These are the parameters on which we can make a diagnosis of failure to thrive. If weight is below the third or fifth percentile, second is failure to gain weight over a period of time. Third is change in rate of growth that have crossed two major percentile on growth curve, 75th to 50th, for example. Means baby was doing okay, but suddenly over a period of time, the growth is now slowing down and the baby is going below the curve or the milestone which he has achieved earlier. So his growth is now falling behind. So that is also one criteria for failure to thrive. And last is weight for height ratio is less than two standard deviation for that age. Statistics and risk factor. FTT, failure to thrive, accounts for 15% of all the pediatric hospital admission. So this is a good number. So plenty of patients are admitted in hospital on account of failure to thrive. The most common cause is undernutrition. Obviously, baby is not taking properly, food is not being given to the baby properly in the adequate amount. So undernutrition is the most common cause. Now, infants have three times the energy need of the adult because they grow very rapidly. Neonate, when a baby, when he or she is born, the weight is around 3 kg, and in first year the weight gets tripled. So you can see the amount of growth takes place in the first year is quite very rapid. So energy needs are much more. Then socioeconomic risk, that is again babies are basically dependent on the parents and the caregiver about their nutrition. So incidence of this undernutrition is more in urban and rural area poverty. When there is food is scarce in the family, then the uh, most younger one, youngest of the family is going to uh, be basically victim of the less food. Moreover, if the in our setup, gender is very important. Female babies are more prone to this failure to thrive. Risk factors of poverty include poor knowledge of infant child nutrition, financial hardship, and social problem and stresses. Second thing is failure to thrive is not this disease that is limited to lower socioeconomic classes. It is present in all the strata of society. If we see the parents who are both working, the nutrition is always compromised in case of kids. They are they are fed on fast food, which is full of calorie, but the nutrients, essential nutrient vitamins are very less. So they all suffer from failure to thrive. So this is not a problem of our poor society. Maternal risk in our part of country, in our country, uh, early are quite common. If the mother is weak, then definitely baby is going to suffer. So if the children of the mothers less than 18 years of age have shown poorer growth in the first year of life, that will eventually lead to failure. Abuse and neglect risk we already discussed. Now, cause of failure to thrive. It can be organic, it can be non-organic. Organic is when we can identify any underlying medical cause, then that is organic. Non-organic is a result of inadequate caloric provision or emotional deprivation. Non-organic is very important because in the majority of the cases of failure to thrive, non-organic cause is the basic reason of failure to thrive. Organic causes plenty of diseases. All the diseases which can lead to decreased appetite or decreased absorption can lead to failure to thrive, like in GIT, malabsorption syndrome, celiac disease, inflammatory bowel disease, pyloric stenosis, gastroesophageal reflux. If we come to cardiopulmonary, congenital heart disease, cystic fibrosis, asthma, likewise in endocrine, hypothyroidism, diabetes mellitus, adrenal insufficiency. Infections are tuberculosis, HIV, chronic parasitic infection of GIT, perinatal infections, renal tubular acidosis, chronic renal failure, neurological, if the baby is mentally retarded or suffering from cerebral palsy, obviously is going to suffer more. Genetically, inborn error of metabolism, cerebral anomalies, then miscellaneous, malignancies, collagen vascular diseases, and leg cancer. You can see all the diseases which are chronic in nature can lead to failure to thrive. So you can number of diseases are there which can be what can be the cause of failure to thrive. Now we come to non-organic causes. 80% of the causes are non-organic. So we should be very careful when we are evaluating a patient of failure to thrive. This may not be a medical problem, but it is a social problem also. So, what are the non-organic causes? Poor feeding skills on the part of parents. These parents have certain taboos that we need to give water feed to the baby because otherwise, after first year of life, we may not accept water. This is the one of the reason of giving water feed to the baby, which is very unfortunate. Then feeding of diluted formula milk. They start in formula milk by looking at other people, but formula milk is very costly. So when the baby start having milk in ample amount, they start making milk with a more of water to make the formula milk pack last longer. That's the misconception or wrong taboos that may be in various societies. Certain foods are rejected, and eventually they make the baby more vulnerable to failure. Poverty, obviously, dysfunctional family interaction, and difficult parent-child interactions. That is obvious from the name of the cause that any family which is having problem, any sort of problem in the day-to-day living, baby's nutrition is going to suffer. Lack of social support, sometimes support from government is less, that can lead to failure to thrive. lack of parenting preparations, more kids, more need of food, and that can lead to neglect. That can basically lead to uh, nutritional deprivation of the babies. Then child abuse and neglect. Female babies are more prone to this abuse and neglect. And then emotional deprivation. So these are important. Then how to approach failure to thrive based on sign and symptom. Like certain sign and symptom will give us clue about the diagnosis. If there is history of spitting, vomiting, and food refusal, we may be dealing with gastroesophageal reflux, chronic tonsillitis, food allergies, or eosinophilic esophagitis. If the baby is complaining of diarrhea or fatty stools, we may be dealing with malabsorption, milk protein intolerance, like IBD or celiac disease. If there is history of snoring, adenoid hypertrophy, if the baby is in mouth breathing with a large tonsils, maybe obstructive sleep apnea. Then, if there is recurrent wheezing and pulmonary infection, that may be sign of asthma, aspiration, food allergy, or cystic fibrosis. If there is history of recurrent hospitalization or recurrent infections, there may be HIV or congenital immune deficiency disease or anatomical defects. And last is travel to or from developing parasitic or bacterial infection or GIT may be there. Now, we come to the clinical features. There is poor growth, obviously. Weight is lower than third percentile. Growth may have slowed or stopped after a previously established growth curve. This growth may have slowed or stopped after a previously established growth curve is only possible to diagnose if we are using growth charts regularly in our OPD. Only then we can pick the baby at the early stage. So again, I want to emphasize that growth charts are very important in the social matters. Okay. And physical skills such as rolling over, sitting, standing, and walking increased means regression of milestones. Then poor development and cognitive function. These are all features of failure to thrive. What can be the symptoms? Baby may be having constipation. He may be having excessive crying, excessive sleepiness, means lethargy, irritability. Baby can be lethargic, baby can be irritable. Minimal smile. Means baby is good. Having very good cry, baby, the social interaction is quite less. Avoidance of eye contact and unresponsive. Now this thing, lethargy, minimal smiling, unresponsiveness, it will lead maybe to a vicious cycle. He is already eating less, but when these symptoms develop, he is more prone to again develop, and that will lead to vicious cycle of this malnutrition. Evaluation. The degree of FTD is measured by weight for age and height for age below third percentile. It means it is quite severely malnourished. Second is progressive decrease in rate of gain of weight or height. Maybe at this moment the baby's weight is okay for the age or height is okay for the age, but is progressively decreasing in velocity of the weight, velocity of the growth. That will give us clue that this baby may eventually land into failure to thrive category or severe acute malnutrition. Now, diagnosis, as we already told you earlier, that this is not a sort of single disease, it is a spectrum. So it depends on history, physical examination, and observation of the parent-child interaction. We need to see how the mother is holding the baby, how much she is showing concern to the baby. If she is basically she is not concerned about what the baby is eating or not taking already, that shows that mother may be the apathy from the mother may be the cause of failure. Detailed lab investigations are required if we suspect there is organic problem. For initial evaluation, following investigation are to be done, like CBC, complete blood count with ESR, then urine and stool microscopy and culture, RFT, urine function test, LFT, liver function test, and serum electrolytes. Weight gain in response to adequate calorie established the diagnosis of psychosocial failure to thrive. If we admit the baby and start giving adequate calories to the baby, it means the baby is not gaining weight. That psychosocial failure to thrive must be the reason for this disease. Management. How we are going to manage the patient. Goals of management are nutritional rehabilitation. We will give the adequate amount of nutrient to the baby. Then second is treatment of the underlying organic cause that is must, and then baby will continue to grow. And last, most important, remedial measure of the psychosocial factors. We may admit the baby to the ward, we may start the micronutrients, give the adequate calories and protein, baby start growing. But we must realize that this baby is going to be back in the same social environment from where he got this failure to thrive diagnosis. So we need to counsel the mother, father about the nutritional need of the baby. That is very important. Only then over all the efforts will be a something. Indication for hospitalization. First, severe malnutrition. Second is diagnostic and lab evaluation needed for organic causes. Then lack of catch-up growth in the OPD treatment. Means OPD treatment had failed, that is an indication of hospitalization. Or we suspect that child is being abused or being neglected. That will we will confirm it only during the hospital. So prognosis is guided by regular monitoring of growth and development. If we manage it early and adequately, prognosis is very good. Now, second part of the lecture is means failure to thrive. We have finished, and I think I have made the topic quite clear to you. So, failure to thrive is an important topic for our theory part and practical part also. Now, abnormalities of head size and shape. Head growth may be affected by abnormal growth of skull bones or alteration in the brain, parenchyma, CSF, cerebrospinal fluid, or bone. So, head growth may be affected by any of these. It may be affected in bones, maybe in brain parenchyma, maybe in CSF. Okay. First is macrocephaly. Now, occipital circumference greater than 2 standard deviation above the mean for the age and sex. Her head is larger than the 98%. So that again we will get from the growth chart. So we see the head circumference at birth is 34 to 35 centimeter, and it grew at 2 months 38 centimeter, at 3 months 40, at 1 year 45 to 46, means 10 to 11 centimeter baby gain in head circumference in first year. In second year, only 1 to 2 centimeter, and at 5 year, baby is having adult head circumference that is 50 to 51 centimeter. This is a picture of baby having macrocephaly. Most probably this is hydrocephalus, which is leading to macrocephaly. The causes can be megalocephaly. It could be benign. Suddenly, we may come across a patient in OPD. We look at the patient, we may see that the head is quite large. But when we look at the head circumference, that is okay. So, or in family, the head circumference of the parents is more than the mouth. Then there could be urocutaneous syndrome, like urofibrosis, lupus sclerosis, Shoes wearable syndrome. Then there is leukodystrophy, lysosomal storage diseases that can lead to rubella and catheter. Then important is increased CSF, as we saw in the last picture, that is hydrocephalus, increased CSF, benign enlargement of subarachnoid space, and hydrocephaly. In hydrocephaly, there is only fluid in the skull department, there is no cerebral tissue. Then enlarged vascular compartment. Now the vascular compartment is enlarged, it will lead to hydrocephalus or develop sepsis. Okay. Uh, it could be AV malformation, brain hemorrhages, subdural hemorrhage, subarachnoid hemorrhage, or intraventricular hemorrhage. Intraventricular hemorrhage is important cause in case of preterm babies who come to know by serial imaging of accidents in the baby. Now baby causes maybe increase in bony compartment like achondroplasia, osteogenesis imperfecta, osteoporosis, and thalassemia major. In thalassemia major, they lead to macula. Then there are serious causes: intracranial mass lesion, cyst, abscess, or tumor, raised ICP, maybe intracranial tension will be raised in lead poisoning, pseudotumor cerebral, and hyperconnesis A. Now we come to another problem in head size, that is microcephaly. Now, microcephaly is when the head size is less than 3 standard deviations below the mean for age, sex, and gestation. They are not there is because babies are growing very rapidly. We need to confirm it from growth chart. If the uh, head circumference is below 3 standard deviations for that age, sex, and gestation. Now, primary microcephaly or secondary microcephaly. Primary microcephaly is used to describe the condition associated with reduced generation of neurons during neural development and migration. Means neurons are less, so development is affected, migration is affected. So there is the primary microcephaly. Secondary microcephaly is when there is insult or injury to the previously normal. Baby was going normally, but there is some event occur that leads to injury or insult, and that causes reduction in number of dendritic process and synaptic connection, and ultimately get to microcephaly. This is a microcephaly baby. Causes of microcephaly, it can be isolated. This is the only like autosomal recessive disorder, autosomal dominant, or X. So only uh, presentation is microcephaly. Syndromic. Trisomies 21, 18, and 13. Monosomies. Various symptoms like Kaidu-Chat, Sackle syndrome, or Williams syndrome that can lead to microcephaly. Structural defect like neural tube defect, then anencephaly, hydrocephaly, or cephalocy, lysencephaly, or schizencephaly. Lysencephaly is when there is when uh, matter is smooth. Normally, the brain is outer surfaces, grooves are there. But in lysencephaly, brain matter is almost smooth. Okay. Then metabolic disorders like phenylketonuria, methylmalonic aciduria, maternal disorder like diabetes. That can lead to infections are always there. Congenital infections like CMV, HSV, rubella, varicella, toxoplasmosis, meningitis. Means tox and meningitis. Then other causes are there, pathogens. If mother is consuming alcohol, tobacco, marijuana, cocaine, heroin, any psychotic drugs like antineoplastic agent, antiepileptic agents, or radiation, that can lead to microcephaly. Now, perinatal insult, HIV, hypoxic ischemic encephalopathy is an important cause of microcephaly. Hypoglycemia, endocrine, hypo, thyroidism, hypopituitarism, and adrenal insufficiency. Next is craniosynostosis. Synostosis. It is defined as premature closure of one or more cranial suture, either major or minor. Okay. Whenever cranial suture get prematurely closed, it can lead to distortion of the shape of skull. It is classified as primary or secondary. Primary craniosynostosis refer to closure of one or more suture owing to a normality of skull wall. While secondary is result from failure of the brain growth and expansion. Incidence of primary craniosynostosis approximately is 1 in 2,000 life. Okay, genetic syndrome account for 10 to 20% of the cases. Etiology, the cause of this is unknown in majority of cases, but prevailing hypothesis suggests that abnormal development of base of skull creates the exaggerated forces of data that act to not disrupt the normal cranial suture plan. So this is just an hypothesis. Second is genetic factors have been identified for many syndromic cranial synostosis. Cranial suture normally fuse during the early childhood. They start with metopic suture that fuse at the age of 2 months, followed by sagittal coronal lambdoid suture at 22 to 26. Premature fusion restricts the growth of skull perpendicular to the affected suture. Okay. If suture get prematurely fused, it can't grow perpendicular to that suture. So when the growth is erected on one side, compensatory skull growth occurs parallel to the affected suture in order to accommodate the growth. एक तरफ वो इसका बांध हो गया दूसरे में ब्रेन ग्रो कर रहा है and that will lead to abnormal shape of the skull. And normally compensatory skull growth takes place parallel to the affected suture because growth was restricted perpendicular to the suture. A normal skull of the screen one we can see. Initially there is a metopic suture. It is between two frontal bones. Then there is anterior fontanella formed by coronal suture and sagittal suture and metopic suture. And there is posterior fontanella, which is formed by lambdoid suture and sagittal suture. Okay, so we can see the various sutures which are there in normal skull. Now, how the shapes are affected when the sutures get prematurely fused, like trigonocephaly, also pointed forehead. Okay, and that is due to premature closure of metopic suture. Then brachycephaly. Now, skull is broad and flattened forehead is there. That is bilateral coronal suture get fused prematurely. Then scaphocephaly. Sagittal suture get closed prematurely and lead to boat-shaped skull, reduced biparietal diameter, and frontal bossing is there. Prominent occiput is there. This is the most common variety. Then oxycephaly, multiple sutures get affected, and it lead to tower type, claw type, or claw leaf type skull with undeveloped sinuses. Lateral and left anterior diagnostic, when the left corner suture get prematurely fused, and right posterior diagnostic, and right lambdoid suture get prematurely fused. So you can see there are various types of skulls are there because of premature fusion of the various sutures. Okay, this A is right posterior diagnostic. Then we can see in D diagram that is trigonocephaly, C is brachycephaly, D and E, left anterior diagnostic, scapulocephaly. Scapulocephaly is the most common. It can occur in various syndrome like Apert syndrome, Fusion syndrome, Carpenter syndrome, or Pfeiffer syndrome. they are associated with some sort of venous aneurysm. Management. Management is quite difficult. It can be only managed by surgical correction if it is done at an earlier stage. Only then there is good outcome and relatively low and moderate. And it is outcome is only good if the baby is not having any other syndromic defect. So especially for non-syndromic infants, outcome is good. Apendectomy is mandatory. When the future gets fused prematurely, it can lead to increased intracranial pressure. You need to cut the skull part to relieve the pressure. So that is an emergency procedure. And multidisciplinary approach is must. Craniofacial team is essential for the long-term follow-up of cases. Thank you very much.